First of all, thanks to the organizers, and this is the last talk for this conference, and I will be speaking on mechanism of resistance and therapy post-resistance in advanced ROS1 positive NSCLC. ROS1 gene, as we all know, is a proto-oncogene, and it is present in the long arm of chromosome 6. It generates two dominant splice variants. Along with that, it also generates shorter isoforms of unknown significance. It encodes ROS1 receptor tyrosine kinase, and this ROS1 fusion gene was first identified in the glioblastoma in the year 1997, and after that in NSCLC it was identified in the year 2007. So ROS1 plays a major role in the activation of several signaling pathways associated with differentiation, proliferation, cell growth, and survival. So you can see here the ROS fusion proteins upregulates the downstream pathway. It is the RAS-RAF, MEK pathway, JAK-STAT, PI3K, AKT, mTOR pathway, and these leads to invasion, proliferation, and survival, migration, and metastasis, and it also increases the translational capacity of the tumor cells. If we talk about the oncogenic ROS1 fusion variant in NSCLC, so there are more than 35 partners identified with the ROS1 rearrangement, and more than 40% of these fusion partners are associated with CD75 and ROS1. FISH has been the gold standard of testing methodology in ROS1 rearrangement, although we are doing NGS platform as much as FISH testing panel, especially the RNA-based NGS panel. This is the timeline of ROS1 in NSCLC advanced setting. So ROS1 rearrangement in NSCLC was first identified in the year 2007, and crizotinib as the first line approval by FDA was given in the year 2016. So this is the first line ROS1 TKIs, especially the crizotinib trials, the profile 1 trial based on which the FDA approval was given. And there are newer generation of ROS1 TKIs that have been approved, including the entrectinib and the repotrectinib. So these three TKIs have been approved by FDA in the first line setting of ROS1 positive NSCLC. Apart from that, the other next generation TKIs include the seritinib, lorlatinib, and taletrectinib. So these have got good efficacy in first line ROS1 positive NSCLC as well. Now come to the mechanism of resistance. We have started with crizotinib, which is the most commonly used drug for the ROS1 positive advanced NSCLC. How did they require the resistance in giving the crizotinib? So we have got inadequate CNS penetration. As we all know, the crizotinib do not cross the blood-brain barrier as well as the other newer TKIs. So other mechanisms include the altered drug target, which can be any kind of mutations, bypass pathway activation, that can be either Parel pathway or another downstream pathway upregulation, and the phenotypic change that can be in the form of EMT or in the form of change in the histology. So intracranial failure is one of the important mechanism of crizotinib resistance, and it is because of poor blood-brain barrier penetration of crizotinib. Crizotinib is a substrate for P-glycoprotein and human ATP binding cassette subfamily efflux transporters, and therefore it do not cross the blood-brain barrier as effectively as the newer TKIs. And the CSF concentration of crizotinib is low, and it has been shown that the overall intracranial response is somewhere between 25 to 33%. Coming to the on-target resistance mechanism, which is the ROS1 dependent mutations. So the ROS1 kinase domain point mutations is seen in somewhere between 50 to 60% of all the crizotinib resistance tumor, and several of these mutations are analogous, that means similar to the ALK, RET, and NTRK resistance mutations. So there are different mutations that are co-mutations and identified in the same tumor or the same cancer, and that is termed as the clonal heterogeneity. These four are the most common mutation or the ROS1 dependent mutation which are seen in our clinical practice. The G2032R mutation is the most common, and it is present in the solvent front of the kinase hinge region of the ROS1 protein. The D2033N is also the common mutation, although it is the second most common, and the third one is the L2026M, which is present in the gatekeeper position of the inhibitor binding pocket. Co-occurrence of genetic mutation of ROS1, they can be either EGFR, ALK, KRAS, MET, BRAF, and TP53. Although these co-mutations are very rare, less than 2 to 3% only, and they typically doesn't occur simultaneously with any other mutation. These are very rare. Although whenever this happens, these are associated with worse prognosis. Coming to the off-target resistance mechanism, although ROS1 independent mechanism, the most common is the bypass pathway activation, which is seen in somewhere between 40 to 44% of all the patients who are having progression of the tumor on crizotinib. So there can be upregulation of the downstream or parallel signaling pathway, and that can be associated with the EGFR, MET, HER2, KRAS, KIT, BRAF, and MEK pathways. Another important mechanism of resistance is the phenotypical change. It can be either in the form of EMT, that is epithelial mesenchymal transition, that is associated with reduced E-cadherin and increased viamentin, and also there can be change in the histology from the adenocarcinoma to the small cell transformation. Here in the figure you can see one of the patient that initially was diagnosed as adenocarcinoma, and at the time of progression and death of the patient, the autopsy was showing that it is a case of small cell lung cancer. So how to approach patients who have progressed on crizotinib? So if there is an oligoprogression, we have to consider ablative therapy and we can continue the crizotinib. If there is a CNS progression only, we should be considering the stereotactic brain surgery or whole brain RT, and we should be considering changing the TKI to a better TKI which has got a better penetration through the blood-brain barrier. However, if there is a gross progression, then we have to consider rebiopsy. Either it can be a tissue rebiopsy or the liquid biopsy, and based on the results of these molecular analysis and the mechanism of resistance, we should be planning the further line of treatment. Coming to the second line treatment which are available with us, they are repotrectinib, entrectinib, lorlatinib, and cabozantinib, and now we have got the taletrectinib as well. Coming first to lorlatinib, it was a phase 2 registration trial, and the total number of patients enrolled in this study was 47, out of which 34 patients were having crizotinib progression. They received prior crizotinib. So if you see the overall response rate in patients who were previously treated with crizotinib, it was 26.5%, and the intracranial response rate was high, ranging to 56%. Next drug is the repotrectinib, which has been approved in the first line setting, ROS1 positive NSCLC. So in this trial, patients who have already received prior lines of ROS1 TKI were also included, and we will be showing you the results of these cohort of patients. So these are the cohort with one prior ROS1 TKI without any prior chemotherapy. Here you can see the patients who were having prior crizotinib, the overall response rate was 39%, and the duration of response among them was 9.2 months. The median PFS in patients receiving prior crizotinib was 9 months, and overall survival in all the cohort of patients was 25.1 months. It was showing a good blood-brain penetration, and if you see the intracranial overall response rate, it was 38% in patients who have received prior lines of ROS1 TKI. Another important part of this trial was that 17 patients who were previously pre-treated with crizotinib-based therapy had ROS1 G2032R mutation, which is the most common mutations, and among them, the overall response rate was 59%. So in resistant mechanism of patients who are progressing on crizotinib, the newer therapy also works. Next drug is the taletrectinib. The phase 2 single arm study was the Trust 1 study, and here the patients who were previously pre-treated with any kind of TKI were included, especially the crizotinib. And if you see, the overall response rate in the patients in the second line setting was 52%, and the intracranial response was also very good, ranging to 73%. The median duration of response was 10.6 months, and median PFS was 7.6 months. There is another trial going on, the Trust 2 trial, which is a larger trial where the cohort 2 and cohort 3 are having patients who have been previously treated with ROS1 TKIs, although the results are still pending. Next drug is cabozantinib, which is all we know that it's a multi-kinase inhibitor, and it has got a clinical activity against ROS1 as well. In an early phase 2 study, major partial response was seen in patients with CD74 ROS1 rearranged NSCLC, those who have progressed on crizotinib, and with a secondary mutation of D2033N, that is the second most common mutation present in the ROS1 positive advanced NSCLC. There are few case reports and series as well that have shown cabozantinib is active in patients who have progressed on first-line treatment with TKIs. Coming to the chemotherapy and immune checkpoint inhibitors, so if the patients have received the available targeted therapies for ROS1 positive NSCLC, we have the option of chemotherapy, which is the standard of care, and pemetrexed-based chemotherapy have shown a better overall response rate ranging from 45 to 60%, and a longer PFS ranging from 5 to 23 months in patients with having a progression on crizotinib-based therapy in the first-line setting. However, most ROS1 positive NSCLC do not express PD-L1, and they are usually associated with a low tumor mutational burden, and therefore the role of immune checkpoint inhibitors has not been revised clearly, and we need further studies on this immune checkpoint inhibitors role in the patient with ROS1 positive NSCLC. However, there are small studies of immune checkpoint inhibitors where it has shown an overall response rate of around 15 to 25% when they are used as a single agent therapy, and up to 70 to 80% in patients who are receiving immune checkpoint inhibitors in combination with chemotherapy. VEGF inhibitors like bevacizumab and ramucirumab, they are all being tried, although the results are still pending. So take-home messages. For all patients with ROS1 positive advanced NSCLC who have progressed on prior line of therapies, molecular analysis has to be done. It can be in the form of tissue NGS or liquid biopsy to look out for the resistance mechanism. The second line TKI, especially the repotrectinib and taletrectinib, have shown good outcomes, and they have got a better blood-brain barrier penetration as well. If the patient has exhausted with all the lines of targeted therapies in the first line setting and second line setting, we have got the chemotherapy option, and in that pemetrexed is the most important chemotherapy based regimen that can be used and had shown benefit in these settings. Role of immune checkpoint inhibitor and VEGF inhibitor needs to be explored, and there are future trials coming up which are looking into this. So with this, I would like to conclude. Thank you. Thanks to the organizers. Thank you.